So this is a case of advanced osteoarthritis knee. Not a simple case, definitely. Came to my clinic 6 months back, and she had proximal tibia fracture along with head injury. So she met with an accident. She was driving bike. She fell down from bike, and she had this. Met with an accident. So had head injury. Admitted her. Treated her for head injury mainly. Proximal tibia. It was a comminuted medial condyle displaced fracture, and when we treated her for head injury, she denied treatment for proximal tibia fracture. So she went to a local guy where they did massage. She came back to me 6 months later with severe pain in her knee and inability to flex or extend her knee. That is, the ROM of knee was reduced, and she was walking with walker since the past 6 months. So she had very severe Varus deformity, which was almost up to 20 to 25 degrees, along with 20 to 25 degrees of FFD because of the displaced malunited proximal tibia fracture, that is medial condyle of proximal tibia fracture, like you can see in the X-ray. Now she came to me with severe pain and inability to bear weight on her leg and reduced range of movement. So we took her up for surgery today. I have explained her the need of total knee replacement because the proximal tibia is malunited. She has severe arthritis of both the knees, mainly right knee because of the trauma, that is post-traumatic arthritis, and the proximal tibia was completely displaced, medially and distally displaced, and there was severe varus deformity because of the displaced proximal tibia fracture. So we took her up for surgery. So implant of choice was gold knee. See, so like you can see now, this is the femoral component, this is the poly, and this is the tibial component. We used very minimal cuts and for tibia mainly, and the poly is 7 size. You can see the cement that we have put over here. And we have used the extension rod. The medial tibia, we have lateralized the tibial base tray. The tray, we have lateralized it a little, and we have filled the defect with the cement after drill holes because it was a sclerotic bone, and medially displaced fragment, we have chipped it off as much as possible. And we have used the extension rod so that the stability of the tibial base plate increases. So this is how you do a TKR for old malunited medial condyle tibia fracture with severe osteoarthritis of knee.